Party down the hall and not paying attention to what.
Oh, that's all right.
And you just give a.
Are we good?
Looks like we're not all back yet, but we are going to get started. Evelyn is going to be speaking about UTI definitions and take you through some case studies. So welcome back, Evelyn.
Thank you. Okay, good morning. How's everybody doing today? Day 2, and most of you are still here. That's very good, a very good sign. Okay, so as Amy said, we're going to spend the next hour or so talking about the UTI definitions in a little bit more detail. Some of you may already have seen this, but in April of this year, they actually did another little update, which was a little discouraging because we were told there were going to be no more changes, but it was not a significant change. It wasn't a really big one. So there is one slide in the presentation today that you don't have in your notebook because of that. But it's just a clarification slide. It's not a big deal. So as we go through this, please feel free again to stop and ask questions. And we'll go through the definitions first, and then we'll move on to the case studies. Does everybody already have their little clickers in their hands? Okay, excellent. Okay, so the first definition that we want to cover is the definition of a UTI. And basically, urinary tract infections are defined using symptomatic urinary tract infection criteria, which is SUTI, S-U-T-I. A lot of times we use these abbreviations, and people that aren't familiar with them don't quite think we're talking a foreign language. But when we say SUTI, that just means it's a urinary tract infection that's symptomatic. Also, the asymptomatic bacteremic UTI, or the ABUTI, and there was a little bit of a change with that this year as well. And then the urinary system infection criteria that it replaced the other, I think it was OUT, other urinary tract infection from last year. So this is just replacing that category and that criteria. And then as we talked about yesterday, the date of event is the date that the element, the first element used to meet that UTI definition or criteria occurs. So for UTIs, we know that they have to have some symptom, right, correct? So for the date of element, it would be when that first symptom appeared, or if the symptom and the culture are done on the same day, then it would be that date as well. So that's the date of event. And it does all need to be within that 7-day infection time frame window. So indwelling catheter, and I think everyone in this room that's been doing infection prevention understands that what we mean when we're talking about UTIs and catheter-associated UTIs is that indwelling catheter has to be inserted through the urethra into the bladder and connected to a drainage bag. The point that I want to make here, however, is make sure all of your nursing staff understand what we mean when we talk about a Foley catheter. When they're counting device days, it's very important for them not to include things like suprapubic catheters, nephrostomy tubes, and oftentimes nurses, if they see something that's going into the bladder and connected to a drainage bag, they might just assume that we're supposed to include those. So make sure that you educate them, or if they have a sheet that they're collecting manually, that you just put on there what we mean by an indwelling Foley catheter. So in and out catheters, of course, do not count. Condom catheters or condom devices do not count as a urinary catheter. And then a couple of years ago, they did change this. If they're having some sort of intermittent, like bladder irrigation through their Foley catheter, we do count those. A few years ago, we did not, but we do count those as Foley indwelling Foley catheters now, and would be included in our device day count as well as our infection count if they acquired a UTI. So the catheter-associated UTI, or CAUTI, is a UTI where there is an indwelling urinary catheter and it was in place for greater than 2 calendar days. So I think everybody has kind of gotten used to the term calendar day now versus time, 24 hours, 48 hours. We used to use that a lot. But those are calendar days, so it's not calculated in our time. So that catheter needs to be in place for greater than 2 calendar days on the date of event, with day 1 being the day the device was placed. So whenever that device was placed, that's day 1, and it needs to be in place for greater than 2 calendar days. And the catheter was in place on the day of the event or the day before. So in order for it to be catheter associated, it's got to be in place greater than 2 days and in place on the day of the event or the day before. Now there is a tiny little change from last year in that we'll go over when we see the definition. So this is just a little something that we put up here as a reminder. You know, how many of you have a reflex culturing process in your institution where they do a urinalysis, right, and they set up certain criterion, and if those criterion are met, they'll send that specimen for a urine culture. You know, there's some different varying opinions on that, whether that's, you know, good or not. I think a lot of times it does help prevent overculturing in some cases, and there may be some of those that you miss, especially now that the abnormal urinalysis has been taken completely out of the picture with CAUTI definition. But that is something that a lot of hospitals are doing. Another thing is one of the practices that's been discussed as to whether it might be helpful or not is if you have a patient that has a long-term indwelling Foley catheter and you suspect a UTI, some hospitals have adopted a protocol where they will change that Foley catheter, and if they still need the Foley, they'll insert a new one before they obtain their culture, with the thought process that that gets rid of a lot of that gunk or the colonization that's had an opportunity to build up on that catheter. Is anyone in here doing that? So we have at least one person. So I actually think that's not a bad idea. And there is one, I'm trying to think if it's APIC that includes that in their recommendations, or the Infectious Disease Society of America, the IDSA group. But there's at least one. CDC doesn't have it in theirs, but there's at least one professional group that puts that in their recommendations. And then why are we culturing urines? A lot of the hospitals I work with, sometimes I have to struggle to find out why they culture the urine. The patient's really not symptomatic per se, but oftentimes, especially in the elderly population, they'll have a change in their mental status, or they'll have a little bit of a bump up in their white count. And while clinically that's probably appropriate, those are not symptoms that we count when we're doing our surveillance. And then, in addition to prevention efforts, strengthening diagnostic practices can improve your CAUTI rates because, again, sometimes you might have a urine culture that comes back positive. The patient is actually treated for that, and they may or may not meet our surveillance definition for a catheter-associated urinary tract infection. So these are the categories. They've simplified it this year. This, I think, those of you that were doing surveillance last year, I really like the new definitions for CAUTI. I think they're much more simple and easier to work with. It's going to be interesting to see what happens to the rates. I'll just go ahead and mention this now. For those of you who are looking at your historical data to determine if you've made an improvement or not, I would go back in 2014, and before I compared my numbers, 14 and 15 for CAUTI, I would take your UTIs that you wrote up with yeast last year out of the equation. So you're really going to be comparing apples to apples to determine whether you've made a true improvement or not. So the categories are SUDI 1A, CAUTI, catheter-associated UTI, SUDI 1B, that's when they have a symptomatic urinary tract infection, but it's not catheter related. And then SUDI 2, and that's for patients 1 year of age or less. So we still have the infant criterion as well. And then we have the asymptomatic bacteremic urinary tract infection, or the ABUTI. And then the final one, as I mentioned, formerly called the OUTI, is now the urinary system infection. So for SUDI 1A, the patient's got an indwelling urinary catheter that's been in place for greater than 2 days on the date of event, not the day of the culture necessarily, but the day of event. And then day 1 is day of device placement. We've already mentioned that. And was still there on the day of event or removed the day before the event. And if you'll notice right here, we've got this little symbol, and down here we have a symbol as well. And what that means is going to be described on the next slide. But basically, when you enter this information into NHSN, you're going to have to indicate if that catheter was present or if it was absent at the time the specimen was taken. So that's one of their little changes that they made in April. And then the patient has to have at least one of the following signs or symptoms: fever, suprapubic tenderness, costovertebral angle pain or tenderness. And you will see, again, this is what they changed in April. And this is not in your handout. The criterion that you have in your handout is what was there in January, and they modified it a little bit in April, but it was after we'd already made your copies. So what they did was they collapsed. If you reference that in your notebook, they actually collapsed that. You know, they have one with the catheter in place, and then underneath it is or if the catheter was taken out. They just collapsed those two, and they added these symptoms. And then there's a little bit more clarification on the next slide. So they have to have the catheter, they have to have a symptom, and then they have to have a urine culture with no more than 2 species of organisms of a bacteria that has a colony count of greater than 10 to the 5th, or 100,000 colony-forming units. All of those elements must occur during the infection time frame window. And then these little symptoms that have an asterisk beside them, that means that there's no other recognized cause. You'll notice that there's no asterisk besides fever, because if they have fever, even if they have another infection at another site, NHSN says you need to count that fever for the UTI, that there's no determination that can be made while the patient is febrile. So these are the updates as of April the 15th, and you do not have to go back to January and re-look at all of your urinary tract infections to see if they met the new or the revised definitions. This is moving forward, but beginning in April, you should apply these changes. So, as I mentioned earlier, with the first little asterisk, when entering the event into NHSN, you choose in place for the catheter. And if you are sending your data electronically to NHSN, make sure that you have that data field filled in your electronic import. And those are for the hospitals that are part of DICON. That's one of the modifications we'll have to make to our database when we send that information over electronically. And then the other little asterisk is you would mark the field remove for the risk factor for urinary catheter. So you are going to have to indicate whether the catheter was in place or if it had been removed the day of or the day before the event. And then, remember I said the asterisk applied to no other recognized cause, because I was a little confused when I saw those symptoms, because I thought, how can they have dysuria and frequency if they've got a Foley catheter? So they did clarify that and said that an indwelling urinary catheter in place would constitute an other recognized cause for patient complaints of frequency, urgency, or dysuria, and therefore these cannot be used as symptoms if the catheter is in place. Now, if the catheter's in the morning and it comes out that day and they have these symptoms, then those can be used. So that is a little bit of change from the way it was in January. Okay? So then the criteria 1B is if the patient does not have a catheter, they've not had a catheter for greater than 2 calendar days, or they did have a urinary catheter in place they did not have a urinary catheter in place on the date of event nor the day before. Did you have a question? Okay. So that's no catheter. If they have a catheter, it hasn't been in place for greater than 2 days, or they did not have it on the day of the event or the day before. They still have to have a symptom, and you can see here the symptoms are what you might expect in someone without a catheter that has a UTI. Of note here, the fever for non-catheter associated UTIs is only in patients that are less than or equal to 65 years of age. So if they're over 65, you cannot use the fever as one of your symptoms to meet your definition. And then the patient has a urine culture with no more than 2 species, at least one of which is a bacteria of greater than 10 to the 5th, and all elements must occur during the infection window period, the same as with SUDI 1A. And then our symptomatic urinary tract infection, SUDI 2, this is for our children or infants less than 1 year of age, and I'm not going to go through all of those, but you can see the biggest difference is in the signs and symptoms. We've added apnea, bradycardia, lethargy, and vomiting to those symptoms that we might see more often in the younger patient population. And then the asymptomatic bacteremic urinary tract infection, or the ABUTI. This definition came into play a couple of years ago when NHSN eliminated the category for asymptomatic UTIs. They added this category, and they said that it was really to accommodate those patients who had the same organism in their urine and in their blood, and to prevent having to call that a primary bloodstream infection. So they created this category to fit that situation. So if you have an ABUTI, the patient can or does not have to have a Foley catheter to meet this definition. If they do have a catheter, then they have to adhere to the rules that it's got to be in place for greater than 2 days, but they do not have to have a catheter. They can have no signs or symptoms that was described in either SUDI 1 or 2 according to the age. Now, this is the change for 2015. Remember, in the SUDI 1B, without the catheter, if they were over 65 years of age and had a fever, you could not count it. So last year, that applied to your ABUTI. But this year, they've clarified that and said that if you have a patient over 65 years of age without a catheter and they do have a fever, you can still include them in your ABUTI definition, which makes sense, because they're going basically by the criteria for SUDI 1A and SUDI 1B. So they do not have to have any symptoms, they can or cannot have a Foley, and then they have to have a urine culture with no more than 2 species, with a colony count of greater than 10 to the 5th, and then they also have to have a positive blood culture with a pathogen that matches the organism in the urine. And those pathogens have to be uropathogens. So they have to be the same ones that are going to meet the definition for a urinary tract infection. Now, this is something that I actually missed the first time I read this, but if they have, this is the recognized pathogen with our bloodstreams. When we start talking about them, there's 2 criteria. One is with a recognized pathogen, right? And the other one is with common commensal. And remember, if they have a common commensal, they have to have a symptom, and those symptoms are fever, chills, and hypotension. But for ABUTI to meet the criterion, if you have a common commensal, you cannot use the fever as the symptom. It'll have to either be chills or hypotension. And I actually missed that, kind of read over that the first time I read this. So just remember that if you've got coag-negative staph in the urine and coag-negative staph in the blood, and you've got your 2 cultures wrong on consecutive days, that fever cannot be the criterion you meet for the blood culture, for the ABUTI. And then, again, all elements must occur during the infection window period, and the rules for the catheter placement apply if they do have a Foley catheter for this. So this is the other category, the urinary system infection category, and they must meet one of the following. They've got an organism isolated from the culture of fluid, excluding the urine, so it cannot be urine, or tissue from the affected site, and this includes the bladder, the urethra, the kidney, or any tissue that's surrounding that perinephritic space. So it must be a positive culture of some fluid or tissue from that site, or they have an abscess or other evidence of infection, or they have one of the following signs or symptoms: fever, localized pain or tenderness, and at least one of the following: either purulent drainage from that affected site, or the organism is cultured from the blood and an imaging test shows evidence of infection. So this is one of the definitions when we get into secondary bloodstream infections, that you actually can use a blood culture to meet the definition of an infection at another site, and therefore you may not have to call it a primary bloodstream infection. And there's several, but this is one of them. And I think NHSN, Crystal, you were in Atlanta, NHSN, I believe, said they were going to come up with a list of those definitions that did include a blood culture to make it easier for IPs to identify those. Is that accurate?
It is.
Okay. And then this is for patients less than 1 year of age, and those are the criterion for those. And again, the symptoms are a little bit different based on the age. So SUDI-1B and other urinary system infections cannot be catheter associated, so there's no Foley catheter on those two criterion. Indwelling urinary catheters that are removed and reinserted. So if they're taken out and put back in, how do you count those, and how is it one episode or is it two separate episodes? So if the catheter is removed, it must be out for at least one full calendar day to start a new episode. So if the catheter is taken out on Monday, is put back in on Tuesday, then that would be counted as one continuous episode for your surveillance as well as for your device counts. But if it's taken out on Monday and reinserted on Wednesday, Wednesday starts a new clock. Okay? So the device must be out for one full calendar day. The UTI repeat infection time frame, remember we talked about this yesterday, so remember it's a 14-day time frame. No new UTIs are to be reported within that time frame. Date of event equals day 1, not the day of culture. And then additional pathogens from urine cultures are added to the event. And again, do not change the device association category if they have, whether it's a Foley catheter or a central line. Do not change that category within that 14-day window if you've already written up an infection at that site. So this is the multiple transfers, and we talked about that yesterday, and I think the next slide explains it a little bit better. So if they're on Unit A on March the 1st, on March the 2nd they go to Unit A, Unit B, and Unit C. And then on March the 3rd, they're on Unit C and Unit D, and that's the date of the event. Remember, we go back to the first unit. They were on the day before the date of event. So that, in this case, would be Unit A. Okay? Now, this may be a little problematic, correct? Because let's just pretend that they were not on Unit A on 3-1. And they just moved to Unit A on 3-2, and they spent very little time on Unit A. However, according to this guideline, that's the one that we're going to have to assign the UTI to. And are most of you now distributing infection data to the unit level and letting them know which infections are theirs? So if I'm the nurse manager on that unit, I may say, I only had this patient an hour. How did they get their UTI on this unit? So once again, this is when we're going to have to explain to them that this is a surveillance definition, and we understand their concern, and hopefully that's not going to happen a lot. but I do think that there is the opportunity for that to happen occasionally. Okay, so you guys ready to start on the case studies? I see some heads shaking and some heads nodding. Do we have any questions about the definition or anything you need clarification on before we start the case studies? Yes? They are not. They are not. Now, that's an excellent question. Her question was, are the non-catheter associated urinary tract infections part of mandatory reporting? And they are not. There's no regulation that says you have to report those. A lot of the hospitals I work with do write those up and do surveillance on them. How many of you do non-catheter associated UTI surveillance as well? Some? Okay. But we know the device is the biggest risk of infection, and in those patients without the device, the opportunities for improvement are different. And so that's really what surveillance is all about, aiming your intervention to address what is preventable. So, but they are not currently required to be reported. Okay, so our first case here, we have a 48-year-old female who's admitted for elective hip replacement, and she has a Foley put in the OR. Her preoperative workup was negative. On day 2, they take the Foley out, which is post-op day 1, and she has no complaints. On day 3, or post-op day 2, she complains of dysuria. She has fever with a temp of 38.6. They send blood cultures and urine cultures to the lab, and her urine comes back positive for greater than 10 to the 5th of enterococcus, and her blood culture is negative. Day 4, she's afebrile, she's on antibiotics, she feels a lot better, and day 5, she's voiding well, and they're getting ready to discharge her. So you've got the case study in front of you. So our choices are, does this patient have a CAUTI, a catheter-associated UTI? Do they have a UTI that's not catheter-related? They have early signs and symptoms of a surgical site infection, or they do not meet any criteria for an HAI. So polling's open now, so look at your choices and make your vote. Okay, we've got 43. Does anybody else want to vote before we look at the answers? Okay, let's see what you guys thought. Oh, my goodness. So we had a lot of difference of opinion. So 40% said they thought this person had a CAUTI. 40% thought a UTI that was not catheter-related. And then about 18% did not believe they met any criteria for HAI. So let's see. So this patient does have a UTI that's not catheter-related. And if you'll look back at the case studies, we'll try to explain why the answers are what they are. If you look back at the case studies, did they have the Foley catheter in place for greater than 2 calendar days? No. So that's kind of the golden rule, and if they do not have that, if they do not meet that, then you know it's not going to be catheter-associated. They did meet the definition of a UTI. They had dysuria, they had fever, and they had a positive urine culture with greater than 10 to the 5th of a bacteria. Okay? Good job. Okay, so our next case study, we have a 75-year-old female who's admitted from the nursing home, secondary to hypotension. She has a history of decreased PO intake, progressive weakness for 2 days, and at the time of admission to the medical surgical unit, the patient is afebrile, she's incontinent, her urine is dark and foul-smelling. She does not complain of any pain or discomfort. They send a straight cast specimen to the lab, and her UA is positive. So this is one that if they had the reflex urines would go on for culture. And they did culture it, but it was negative. On day 3, she continues to be incontinent with skin breakdown, so they put a Foley catheter in to protect her skin. And she has difficulty taking her diet and chokes easily. On day 5, she becomes unresponsive with fever. She has a drop in her O2 sats, and they call a rapid response team to intervene. They send her to the ICU. They put in a central line and intubate her. And remember, she's already got her Foley catheter in that was put in on day 3. They do a chest x-ray, and it's positive. They do blood cultures. 1 of 2 is positive for serratia, and her urine culture is positive for greater than 10 to the 5th of serratia. So let's look at that a minute and see what you think. So we've got the first question here on this lady is, how should we classify this infection? Does she have something that's present on admission, or does she have a healthcare associated or a hospital acquired infection? Okay, we've got 44, so let's see what you guys think. Okay, so almost 75% thought it was an HAI, and that is correct. She does have a hospital-acquired infection. And then our next question on her is, what specific criteria is met? Does she have a laboratory-confirmed bloodstream infection? Does she have a CODI with a secondary BSI? Does she have a SUDI with a secondary BSI, or an asymptomatic bacteremic urinary tract infection, or a BUDI? We need some music. You guys are way too quiet. Get a couple more responses and we'll see what our answers are. Okay, so let's see what you guys thought. So 65% think that she's got a CODI with a secondary BSI, and some believe she had a symptomatic UTI, which would mean it was not Foley related, remember, and then asymptomatic urinary tract bacteremia. So let's see who's right. And so she does have, yes?
Well, you said asymptomatic, I mean, I know it's a catheter associated, but I'm just sitting here thinking a SUDI 1A is a CODI. So wouldn't C also be right? Because it is a SUDI.
But SUDI 1B, that, yeah, right. So in this one, we didn't call it if I had said a SUDI 1A, then you're correct. But we just said symptomatic UTI, and next time I might need to clarify SUDI 1B instead. But so she had a catheter, right, and she'd had it for greater than 2 calendar days. She had a symptom, and because she had catheter, her age didn't eliminate the fever as a symptom. And then she had the same organism in her blood that she had in her urine. So that's why we can call this a secondary BSI. When we get into the secondary BSI scenarios, they've really changed that this year, and your options are much more narrow for what you can call secondary. But anytime the organisms match in the blood and in the urine or the other site, if that site-specific definition is met, then it can be secondary to the primary site. Okay, so case study number 3, we have a 59-year-old female who's transferred from another healthcare facility to your hospital. She already has a Foley catheter in place at time of transfer. She has no complaints. They go ahead and do a routine urine and obtain a culture, and she has 10,000 colony-forming units of yeast in her urine. On day 2, she has a low-grade fever of 100, still no complaints. And on day 3, she spikes a temperature of 102. She has blood cultures and urine cultures obtained. Her blood cultures are negative, and her urine culture is now positive for greater than 10 to the 5th of yeast. So does this meet site-specific criterion for a healthcare-associated infection? Yes or no? Okay. So 82% said no, and we had a few that said yes. And why is the answer no? Those of you who got it right? Yeast. So yeast is not a uropathogen, so even though she had fever and she had greater than 10 to the 5th, according to the 2015 definitions, we cannot count it. Yes, Vicki?
Is there a list of organisms, either in our handouts or on the website that we can refer to? For example, I'm thinking of Staph aureus. Is that considered one of the typical urinary pathogens?
Right. So Vicki's question was, is there a list of organisms? And there is. And basically what NHSN says for urinary tract infections is it must be a bacteria. It cannot be a fungal organism or mold or any of those. So any bacteria can qualify as a uropathogen, so Staph aureus would certainly qualify. But there are lists of organisms as we get into what can be called secondary based on the primary site, and those are all listed on the NHSN website within those protocols for each surveillance definition. Case study number 4, we have a 66-year-old patient that's in the ICU. They had an exploratory lap. Foley was inserted on the day of surgery, but it's removed on post-op day 2. So they had it on the day of surgery, and it's taken out on post-op day 2. On post-op day 4, they complain of diffuse abdominal pain and spike a temp of 101. They have elevated WBCs, and their urine is slightly cloudy. They send a urine secondary to the signs and symptoms, and the culture comes back greater than 10 to the 5th of Pseudomonas. So think about that one a minute. And then tell me if you think this patient has a CODI, if they have a UTI that's not catheter related, if they have early signs and symptoms of a surgical site infection, or do they meet any criteria for an HAI? We've got 36 respondents. A few more you guys want to vote? I'm stuck on 41, so we'll go ahead and see what you guys thought. All right, so 56% thought that the patient has a UTI that's not catheter related. Okay, and then we had 7% that didn't think they met criteria, 24 think they have a CAUTI, and 12 they've got early signs and symptoms of a surgical site infection. So the correct answer is they do not meet any criteria. And I see some people cheering back there. They got it right. Do you want to tell us why?
She's over 65.
Okay, so she's over 65, so the fever, you cannot use the fever as a symptom. What about the diffuse abdominal pain? Did that trick anybody up? She had the exploratory lap, and remember, diffuse abdominal pain does not equal suprapubic tenderness or costovertebral angle pain. So, and there certainly is another recognized cause for that pain, and so that's why she did not meet our definition. Okay? Any questions from anybody that, yes?
I just want to make sure that I'm thinking about this right. If the patient did have a Foley in for greater than 2 days, then it doesn't matter about their age.
That's correct.
Okay.
That's correct. The age only comes into play if the Foley catheter is not in there. If they do not have the Foley, yes.
I just have a problem with the discrimination of the age.
Hey, I'm right there with you, so I understand. Sometimes it works in our benefit and sometimes it doesn't. Okay, so case study number 5. On day 1, 53-year-old male suffering trauma after falling from a roof at a construction site. They're admitted to your SICU after being taken to the OR for an ORIF of the radius and the ulna and femur. Patient was intubated and has a central line and a Foley catheter put in. On day 5, they're doing much better. They've been weaned from the ventilator. The central line and the Foley are removed and a peripheral IV is inserted. On day 6, they're stable and transferred from the SICU to the orthopedic unit. On day 7, the surgical site is healing well. He's voiding well and has no complaints of discomfort. But he has an elevated WBC on his daily labs, so they send cultures, a urine culture, do a chest x-ray. Of the blood cultures, 1 of 2 is positive for VRE, and they also grow VRE in their urine. So they're in the OR, transferred from the SICU on day 6, and then they have a bump up in their white count on day 7. So do we think that the urine and blood cultures are probably a contaminant? The patient has a UTI with a secondary bloodstream infection. They have a primary bloodstream infection since the VRE in the urine is probably a colonization. Or the patient has an asymptomatic bacteremic UTI. I'm going to bring Pandora tomorrow for our little response polling time. Okay, so 42. Does anybody else want to vote? Great. Okay. So let's see what you guys think. I bet you got this one right. Very good. 75%, almost 75% think the patient has an asymptomatic bacteremic UTI, and that's correct. They have the same organism in their urine that they had in their blood, didn't have any symptoms that meet our definition for urinary tract infection. WBC is not part of that, which for those of you who are just starting out in surveillance, that's a good tip. Your resources are probably very limited, so don't spend a lot of time looking at elements that you cannot use to meet your definition. So WBC is almost never. It is part of one definition at least, but it's almost never part of the definition, so that's really not where you want to spend your time and energy, looking at things that are not going to be used to meet your definition. It's nice to know, to have a good picture of the patient, but if your time's limited, then that's one way you can redirect your surveillance efforts. So this is a real case study that I encountered in one of my hospitals. So this is a 73-year-old male who was admitted with complaints of chest pain and shortness of breath for 2 days. At the time they were admitted, they complained with problems with urination and stated that they felt a lot of difficulty voiding and had frequency as well with urination. The physician's assessment includes dysuria and rule out UTI. So on the day of admission, they send a urine and a urine culture. The urine culture is positive for greater than 10 to the 5th of multiple bacterial morphites. Hope I'm saying that correctly. So on day 2, on 3/17, the patient has no complaints. On 3/18, he complains of frequency again. They send a UA, and it's negative. On the 19th, he complains of dysuria and frequency. On the 20th, he continues to complain of frequency, so they put a Foley catheter in. And on the 21st, they send another urine and urine culture that comes back positive now for greater than 10 to the 5th of Enterococcus. So let's see what you think about this gentleman. So does he meet the definition of an HAI? Does he have a COTI? Does he have a UTI that's present on admission? Or a HAI UTI? We've got 39 responses. A few more want to weigh in on this one. I can't see how you're voting, but I can see if you're voting. Okay, so let's see what you guys think. So almost half think that they've got an HAI UTI, and just under 40% think they had a UTI present on admission, and then the other two are kind of scattered. So the correct response is they've got an HAI UTI. This is a good example of how this person definitely came in with urinary tract symptoms, right? They didn't meet the definition at time of admission. Why? The urine culture, clearly, it did not speciate a certain organism for one thing, and then it clearly had more than 2 species. So that's why he did not meet the definition at time of admission. He had not had his catheter in for greater than 2 days, is why it was not a COTI, but he did have symptoms of frequency, and his urine culture had greater than 10 to the 5th of Enterococcus. So that's why he met the definition of a regular UTI, healthcare associated.
So anytime there's more than 2 organisms, you don't count it?
That's correct. So her question is, if the urine culture has more than 2 organisms, you cannot count it. So in the example of, let's say, this individual, if he had greater than 10 to the 5th of Enterococcus, and then he also had mixed flora in that urine culture, you would not count that either, because mixed flora insinuates that there's more than 2 organisms present, along with the one that you've identified. So that would not, those urine cultures are automatically eliminated if it has mixed flora in the urine culture report. So the next case study, number 7, we've got a 52-year-old female admitted from home. The daughter states that her mom has had increase in confusion over the past several days with poor PO intake and retention of urine. She's had no diarrhea, fever, vomiting, and so they put a Foley catheter in the ED. On day 2, she spikes a temp of 101. They order chest x-rays and cultures. Her blood is negative. Her urine culture did not get sent. That happens quite often, doesn't it? And then on day 3, there's no change in her status. On day 4, the physician recognizes that the urine culture did not get sent and orders another one that is now positive for greater than 10 to the 5th of Proteus. So she has a Foley put in when she comes in. Her urine culture, she spikes a temp on day 2. They forget to send the urine culture until day 4. So let's see what you think about this. So she does not meet any HAI definition. She does have a CODI. She has a UTI with a secondary bloodstream infection, or she has a UTI that's present on admission. Okay, we've got 42 votes, so let's see what you guys think. All right, so 40% think they've got a UTI present on admission. Nobody thinks they had a secondary bloodstream because we didn't have a positive blood culture, right? And then 51% believe they have a CODI, and 9 think that they have do not meet any HAI definition. Now, I will tell you, when I went back and looked at these, there's actually 2 right answers for this one. You knew that back there, didn't you? So the one that is right, that's identified here, is they do not meet the HAI definition. And the other one that's right is D. So those of you who said a UTI POA, you're correct as well. So the reason that they do not meet any HAI definition is why. The why is it present on admission? What's the date of event? Day 2. So remember, if the date of event is on the day of admission or the day after, even though the urine culture is done later, as long as that urine culture is done within this 7-day window, you're going to be able to count that as POA and not an HAI. Okay? Yes?
On that one, the people would be the day of event.
That's correct. That's correct. That's the first symptom that's used to meet the definition of the UTI.
I don't hope I'm confusing me with this question, but as of last year's definitions, it would have caught up the county because the culture was collected, right? 'Cause you didn't have all-
That's correct.
Okay.
That's correct. And that's one of the biggest changes that people that have been doing this for a while struggled with, because last year all of your elements of your criterion had to be present on day of admission or the day after in order for it to be POA. If it was calendar day 3 or after and all the elements were present, it was an HAI. So this is really going to have the potential to impact people's rates. because it's no longer all the criterion, it's the first. All right, in case study number 8, we got Grandma Unlucky is admitted to the hospital. She's unconscious because she went skiing at the lake on the 4th of July. So she does look a little bit unlucky up there. And on day 1, she has a broken femur. They put a Foley and a peripheral IV in. On day 3, her Foley is removed. She's awake and making good recovery. On day 4, she's up with assistance but complains of pain on voiding. They send a urine, and she's got 15 WBCs and some leukocyte negative nitrites. And on day 5, they collect a urine culture that has 10 to the 4th colony-forming units of E. coli. So does this patient have a CODI, and if so, what type? So look at your choices and determine, first of all, if she does have a catheter-associated UTI, and if she does, what type would it be? You guys hungry? You're slowing down. Okay, so we've got 42 responses, so let's see what you thought. So almost 60% thought no UTI, and that's correct. Does anybody want to tell the rest of the group why? So they did not meet one of the fundamental pieces of the definition, which is greater than 10 to the 5th. So when you're doing your surveillance, that's another way you can increase your productivity, is if that urine culture doesn't have 10 to the 5th of an organism of a bacteria, you don't have to work it up. You don't have to look any further. You can just automatically discard that one. Okay? So case study number 9, we've got a 58-year-old patient that's admitted to the ED with a GI bleed. They put a Foley in. They spike a temp of 38.6, and they send a urine specimen on day 2. On day 3, they have 10 to the 5th of Pseudomonas from the urine that was sent the day before. They're afebrile and asymptomatic, and they start them on antibiotics based on the culture results. On days 4 and 5, they're asymptomatic and afebrile. So question 1 is this an HAI? And if so, what type? Okay, get a couple more people to vote. We'll close it. Okay, see what you thought. So 71% thought that it was a UTI that was present on admission. And that's correct, because the date of event was day 2, right? They spiked the fever on day 2. All right, so we're going to go a little bit further with this case. And this person is still in the hospital. They kept their Foley all of this time. They completed their treatment for their UTI that happened on hospital day 2. Their hospitalization has been complicated by development of a DVT. They've been afebrile up until today, although the temperature has been kind of edging up for the last 2 days and is now 38.1. They have some productive cough and rhonchi present in their lung. On day 15, their urine's cloudy, they're afebrile, the cough continues, so they send urine and sputum cultures. And then on day 16, the urine and the sputum are both positive for Staph aureus, and in the urine, that's greater than 10 to the 5th colony count. So think about that a minute. And then, do we believe that this person has a second UTI because the first one was resolved and treated? No, it's an extension of the first UTI. Or no, the UTI is secondary to a respiratory infection. Okay, let's see what you thought. So almost 50% thought that this was an extension of the first UTI, and that's correct. And the reason is, remember, the 14-day start with the date of event. So the date of event was day 2 in the first UTI. The next date of event was on day 13, so that was within that 14-day window. And that's why we would not report this as a second urinary tract infection. Now, what do we do with that Staph aureus, though? We have to go back and add it to the original UTI. Now, if you're not doing surveillance for non-Foley UTIs, it will not be quite as complicated, but if that's reportable to NHSN, and you've already reported the first one to NHSN and they have a second one during that infection window, remember to go back and add that pathogen to the first CAUTI that you've already sent to NHSN. Okay, so this says case study 11. It's really 10. Sorry. We didn't skip 10. So on April the 15th, we've got a 59-year-old female that was admitted with uterine cancer. They put a Foley in on admission. They do a total abdominal hysterectomy on the 16th. On the 18th, she's progressing well until she spikes a fever of 101.3. They draw blood cultures that are negative. On the 19th, she's asymptomatic. On the 20th, she's asymptomatic. On the 21st, they send a urine for greater than, and that comes back positive, greater than 10 to the 5th. On the 22nd, she's asymptomatic. And on the 23rd, she remains asymptomatic, and they take her Foley out. So what do we think about this lady? Does she have a UTI? And if she does, what criterion were met? This is our last one. Okay, you guys got to vote. We've only got 29. Okay. All right, Grace, so let's see what you think. So 51% believe that it is a SUDI, criterion 1A, which is fully related, correct? And that is the correct answer. So does anybody have any questions why that was what it was, even though she was asymptomatic? That last year, remember, we had a gap day and all of those kind of other caveats. Those are gone away now, so we don't even think about a gap day any longer. So she had her date of event, and her urine culture was positive within that 7-day window from the date of event. That's why she met the definition. Okay? All right, and then this is a little funny email break. This is actually an email that NHSN got from one of their users that said they were looking at a patient that presented to the facility on February the 15th of 13. They had a Foley put in the ER on the same date. During her stay, she was afebrile and symptom-free with one exception. She had a temp of 102, documented on 3/1. The nurse manager thought that that was a misdocumentation, and the IP would like some guidance. Does she still have to count this as a CAUTI? What's the answer? Yes. So NHSN does get, I'm sure, get a lot of emails that probably provide them with a little chuckle from time to time. So we are right on time. We've got about 4 minutes before lunch. If anyone has any questions about the UTI definitions, about any of the case studies, why you thought your answer was more right than the one that I said was correct, we're happy to discuss all of that. Any questions or any comments? Yes.
So, question number 10 that actually says number 11.
Mm-hmm.
So that was actually a CAUTI, right?
It was.
Because it says SUDI.
It's SUDI category 1A, criterion 1A, and that is a CAUTI. Yes.
That was what confused me about it.
Right.
Just that word.
And when we interchange it like that, I understand the confusion. You know, sometimes I'll say CAUTI and sometimes I'll say 1A, but 1A is catheter related, 1B is not, and 2A is for your children under the age of 1.
But now there's not a 1A and 1B, correct, since April?
No. There is still a 1A, a SUDI 1A, and a SUDI 1B. What changed in April is under 1A, they had a set of criterion for if the Foley catheter had been in place for the entire day of the date of event, and then they had one for if it had been removed, and they collapsed those two and added some signs and symptoms. Yes?
If a patient has a CAUTI with a secondary bloodstream infection, do we then go out and report it? We had a CAUTI, or how does NHSN look at it?
So her question is if they have a CAUTI and a secondary BSI, is that correct? How do you report that?
Yeah, I mean, like if we're trying to educate, I mean, and also, does CMS look at that as a CAUTI?
Yes. So if they meet your definition, and this is true for any other primary site of infection, if they meet the NHSN definition of an infection at that primary site, and they have a bloodstream infection that meets the criteria for a secondary bloodstream infection, which we're going to talk about on Thursday, I think, then that would be reported for the primary site. And there's always a question in there, did the patient have a secondary bloodstream infection? And you would respond yes. But unless it's MRSA in the blood, you would not need to report it any other way. If it happens to be MRSA in the blood, then you're still going to have to report it as an MRSA lab ID'd event, but not as a primary bloodstream infection. Okay?
But for CMS purposes,
It will be a CAUTI.
in the hospital for reimbursement purposes.
It will be a CAUTI. That's the way it'll go over. Okay? Any other questions? Okay, I think we're right on time.
So we have lunch, and Kirk and I will be at either door to give you a ticket. Lunch today is upstairs, so if you'll head down the hall to the atrium, turn left. There's a stairway and also a set of elevators to go upstairs, and the lunch will be set up there. And please be back at 1 o'clock.